Hello, everyone. It's Dr. Locklear here, and today I'm talking with you about Exemplar 9E, and this is pneumonia, and it falls under the concept of infection, which is Module 9. We'll be beginning our uh, recording on page 622 in your Pearson text. So describe the pathophysiology of pneumonia. How does pneumonia come into play? We know it's usually caused from some type of bacterial infection. What is, again, the causes? What happens when you get infected? What is the process? What are the risk factors? How do we prevent it? And we know, just dealing with COVID, that wearing a mask is very beneficial for airborne diseases. What are the clinical manifestations? What will you see with a person with pneumonia? What are diagnostic tests? What types of therapies? Breathing treatments, antibiotics, oxygen therapy, palpation and percussion on the chest to loosen secretions. There's multiple things that we can do. How do we differentiate care of people with pneumonia from infants to the older adult? And how do we use the nursing process to assess? Lung assessment is imperative, skin assessment, because that identifies if we're perfusing. So we don't just listen to lungs, we want to listen to our heart and look at the skin and capillary refills and O2 sats. Listen to the cough, look at the cough. Is it clear, yellow, green? All of these are important. And your WBCs, your elevated temperature, all of that. Let's get started. So our overview: inflammation of the lung parenchyma, the respiratory bronchioles and alveoli, as a result of infection is known as pneumonia. So you have inflammation. Despite significant advances in antibiotic therapy, pneumonia and influenza together are the 8th leading cause of death in the United States and the leading cause of death from infectious diseases. That's high. Hospital-acquired infections such as ventilator-assisted pneumonia, VAP, occur more commonly in older adults and in patients with weakened immune systems. The respiratory system is constantly open to possibility of infection because we're constantly breathing in all kinds of viruses, bacteria, allergens. The respiratory tree is exposed to the environment as air moves in and out of the lower respiratory tract. In addition, huge numbers of microorganisms in the oropharynx may be aspirated into the bronchial tree, so it's coming in through our nose and through our mouth. Both anatomical and physiologic defenses help to maintain the sterility of the lower respiratory tract. So we have defenses because if we didn't, we'd be all die from these bacteria and viruses that we breathe in. When these defenses are impaired, the risk for infection increases. For example, drugs, alcohol, neuromuscular diseases that suppress the cough reflex. Coughing helps us clear these mucus out of our throat that helps get rid of these bacteria and viruses. So when that's impaired, that secretions are settling in our lungs. Asthma can both narrow and inflame airways, trapping mucus and impairing oxygenation. And the influenza virus can leave the respiratory epithelium vulnerable to bacterial infection because it damages it, so it damages that protective layer. Even in healthy people, microorganisms and other foreign material occasionally enter the bronchial tree and the lung parenchyma. Disorders affecting the lower respiratory system below the larynx can affect the ability to effectively move air into and out of the lungs, ventilation. We got to be able to breathe. Exchange oxygen and carbon dioxide across the alveolar capillary membrane, which is respiration, and maintain clear and patent airways and ventilate the lungs. Organisms causing such disorders can enter the lung in several ways. The most common means of entry is aspiration of microcutaneous secretions from the oropharynx. Microorganisms may be inhaled following release when an infected individual coughs, sneezes, or talks. Inhalation of contaminated aerosolized water can result in viral and some other types of pneumonia. Bacteria also may spread to the lungs through the bloodstream if you've got an infection elsewhere in the body. Regardless of the means of entry, host defenses must be overwhelmed either by the number of organisms or by their virulence or disease-causing ability for an infection to develop. So when they do like sputum cultures, they will see how much bacteria is growing. So when you do a culture, if your bacteria count is over 100,000, then you're considered to have an infection. And so as this occurs, you will see that the more bacteria growth you have, the more it overcomes your lungs. So what is the patho and the etiology? When invading microorganisms colonize the alveoli, and that's a lot, they're growing there, colonization is a lot, they initiate an inflammatory and immune response. The immune system is trying to fight. The antigen antibody response and endotoxins released by some organisms damage bronchial and alveolar mucous membranes, which causes inflammation and vascular congestion and edema, thereby limiting our ability to breathe. Infectious debris and exudate can fill alveoli, interfering with ventilation and gas exchange. So it's kind of trapped there. Pneumonia may develop in one of four distinct patterns: lobar pneumonia, bronchopneumonia, interstitial pneumonia, and miliary pneumonia. The pathologic process, anatomical location, and manifestations of pneumonia vary according to the infective organisms. Bacterial and viral pathogens act differently within the lungs. Bacterial pathogens circulate through the bloodstream to the lungs where they damage cells. Cellular debris and mucus cause airway obstruction. Bacteria tend to be distributed evenly throughout one or more of the lobes of a single lung, a pattern termed unilateral lobar pneumonia. Means it's on both sides. Viruses frequently enter from the upper respiratory tract, infiltrating the alveoli nearest the bronchi of one or both lungs. There they invade the cells, replicate, and burst out forcefully, killing the cells and sending out cell debris. They rapidly invade adjacent areas, distributing themselves in scattered, patchy pattern referred to as bronchopneumonia. And you have table -911 on 623 that talks about lobar, broncho, interstitial, and miliary, and it gives you the description of it. Aspiration of food, emesis, gastric reflux, or hydrocarbons cause a chemical injury and an inflammatory response. Materials with a lower pH cause more inflammation, which sets the stage for bacterial invasion. Pneumonia may either be infectious or non-infectious. Bacteria, viruses, fungi, protozoa, and other microbes can lead to infectious pneumonia. Non-infectious causes include aspiration, so aspirating food like gastric contents, and inhalation of toxic or irritating chemicals. So it's not always just bacteria or viruses. Pneumonias often are classified as community-acquired, healthcare associated, or opportunistic, which means if your body's compromised, like with AIDS or cancer, then you're way more susceptible because your immune system's compromised. Remember, we're fighting off bacteria and viruses all the time. Different organisms are implicated in each of these classifications. So you have table 9-12, common organisms that cause pneumonia in adults. And I'm not going to ask you that on a test. That's just way too much for you to try to remember. But it is good to know, what kind of the bacteria are. The most common causative organisms for community-acquired pneumonia is Streptococcus pneumoniae, also called pneumococcus, a gram-positive bacterium. Now, it's important to understand there's gram-negative and gram-positive because that determines which type of antibiotic will treat that particular bacteria. This organism causes approximately 50% of the cases of community-acquired pneumonia, leading to hospital admission, Staphylococcus aureus, which is hard to treat, and gram-negative bacteria are often implicated as healthcare-associated causes of pneumonia. Organisms such as pneumocystis, Javeshi, generally cause infections only in individuals who are immunocompromised, those opportunistic infections. The etiology. There are several different classifications of pneumonia are based on the infecting organism, including acute bacterial pneumonia, Legionnaire's disease, primary atypical pneumonia, viral pneumonia, pneumocystitis jirovecii pneumonia, and aspiration pneumonia. So it's not just one bacteria, there's many. So acute bacterial pneumonia. Of the bacterial pneumonia, the pathogenesis of pneumococcal Streptococcus pneumonia is best understood. These bacteria reside in the upper respiratory tract of 70% of adults. They may spread by direct individual-to-individual contact via droplets. In many cases, infection results from aspiration of resident bacteria. The typical pattern for pneumococcal pneumonia is lobar pneumonia, and you can see that on table 911. Although it may present in a pattern more typical of bronchopneumonia, the lower lobes of the lungs are usually affected because of gravity. Okay, and here's your kind of a picture of some pleural effusion here. So what is pneumococcal pneumonia? Pneumococcal pneumonia typically resolves uneventfully. Normal lung structure is restored on completion of the process. Local extension of the infection to involve the pleura, pleuritis, is the most common complication. Pneumonias caused by Staphylococcus aureus and gram-negative bacteria often cause extensive peritoneal damage with necrosis, lung abscess, and empyema, or pleural effusion. This is an accumulation of excess fluid in the pleural cavity, so you're pretty sick at this point. Progressive destruction of lung tissue and functional impairment are possible consequences of Klebsiella pneumonia. And so these are really hard to treat. A lung abscess is a local area of necrosis and pus formation with the lung itself and is relatively uncommon. The manifestations of lung abscess develop slowly and include weight loss, malaise, night sweats, fever, and a productive cough. Sputum is foul smelling and tasting, and it smells. When you smell it, you will know what it smells like. Rupture of the abscess into a larger cavity airway or a larger airway is heralded by the production of copious amounts of purulent sputum. And so it's nasty. I hate to say that, but it's nasty. Empyema is accumulation of purulent exudate in the pleural cavity. It is identified by chest X-ray or CT. Thoracentesis, which is where they insert a needle into the pleural space to remove fluid accumulation, may be done, or a chest tube may be inserted to allow continuous drainage of the purulent exudate. The presentation of bacterial pneumonia is usually acute with rapid onset of shaking, chills, fever, and cough that produces rust-colored or purulent sputum, and rust-colored means it may have a little blood in it. Chest aching or pleuritic pain, sharp, localized chest pain that increases with breathing and cough. So every time you take a deep breath, it hurts because it's so inflamed in there. Limited breath sounds and fine crackles or rills are heard over the affected area of lung. A pleural friction rub may be audible if the involved area is large and gas exchange is impaired. Dyspnea and cyanosis may be noted. A more insidious onset with low-grade fever, cough, and scattered crackles is more typical of bronchopneumonia. However, dyspnea is less common with bronchopneumonia. The older adult or patient who is debilitated may have atypical manifestations of pneumonia with little cough, scant sputum, and minimal evidence of respiratory distress. So they may not think much of it and not get treated. Fever, tachypnea, rapid respirations, and augmentation or agitation may be the primary presenting symptoms. And then you have something called Legionnaire's disease, and this is a form of bronchopneumonia, and it's caused by the Legionella bacterium. It occurs sporadically. The symptoms develop gradually. You have dry cough, dyspnea, malaise, chills, fever, headache, confusion, poor appetite, diarrhea, myalgias, which is muscle pain, and arthralgias, which is joint pain. Patchy, lobar lung tissue consolidation, and there is a high risk of mortality with Legionnaires. Primary atypical pneumonia. This is pneumonia caused by Mycoplasma pneumoniae. It's generally classified as primary atypical pneumonia because its presentation and course differ significantly from those of bacterial pneumonias. Mycoplasma infections often cause pharyngitis or bronchitis. When this type of pneumonia develops, patchy inflammation changes occur in the alveolar, sputum, and in interstitial tissue of the lungs. Alveolar exudate and consolidation of lung tissue are not features of atypical pneumonia. Young adults, college students, and military recruits in particular are populations that are affected. Primary atypical pneumonia is highly contagious. Manifestations resemble those of viral pneumonia, systemic manifestations of fever, headache, myalgias, arthralgias, and often these are just overwhelming. Like it says here, it predominates. The cough associated with atypical pneumonia is dry, hacking, and non-productive, and it is non-stop too. Because of the typical mild nature and predominant systemic manifestations, mycoplasmal and viral pneumonia are often referred to as walking pneumonia. So you have the symptoms, but they're not quite as bad as like the viral or the bacterial pneumonia. Viral pneumonia, approximately 10% of pneumonias in adults are viral. Influenza virus and adenovirus are the most common organisms. And then the cytomegalovirus also can cause it with patients who are immunocompromised. Other viruses such as herpes, measles may also cause viral pneumonia. As in primary atypical pneumonia, lung involvement in viral pneumonia is limited to the alveolar septum and interstitial spaces. I think I said sputum a while ago, but it probably should have been septum. These bifocals just cause me to see things I shouldn't see sometimes. Viral pneumonia is typically a mild disease that often affects older adults and people with chronic conditions. It usually occurs in community epidemics. Flu-like symptoms, headache, fever, fatigue, malaise, and muscle aching are common, along with a dry cough. So all of them have a cough. All of them have pain with breathing. Remember, it's in the lungs, so there is inflammation going on there. Pneumocystitis. Individuals with AIDS and others who are significantly immunocompromised are at significant risk for developing an opportunistic pneumonia called pneumocystis jirovecii. That's a hard word to say. It's a common parasite found worldwide. Immunity to this pneumocystitis is nearly universal, except in those who are immunocompromised. Opportunistic infections may develop in patients treated with immunosuppressant or cytotoxic drugs for cancer or who have undergone organ transplantation and in patients with genetic or acquired immunodeficiencies. Infection with the P. jirovecii produces patchy involvement throughout the lungs, causing affected alveoli to thicken, become edematous or inflamed, and filled with foamy protein-rich fluid, so that makes gas exchange very difficult. Gas exchange is severely impaired as the disease progresses. It has an abrupt onset with fever, tachypnea, shortness of breath, and a dry, non-productive cough. Respiratory distress can be significant with intercostal retractions and cyanosis. And so those intercostal retractions, that's your ribs, and it hurts to breathe. It's very, very painful. Aspiration pneumonia. This is aspiration of gastric contents into the lungs, results in chemical and bacterial pneumonia known as aspiration pneumonia. You see this a lot with stroke patients. Major risk factors for aspiration include emergency surgery in which the patient was not NPO 8 hours prior, emergency C-section, for example, depressed cough and gag reflexes and impaired swallowing. Older surgical patients and those with advanced dementia are at significant risk. Enteral nutrition by either nasogastric or gastric tube also increases the risk for aspiration pneumonia. Vomiting is not always apparent. Silent regurgitation of gastric contents may occur when the level of consciousness is decreased. Measures to reduce the risk of aspiration include elevating the head of the bed, minimizing the use of preoperative medications, promoting aesthetic elimination from the body, preventing nausea and gastric distension, serving thickened liquids using something called Thicket, and performing swallowing tests, especially for patients who have had a stroke. The low pH of gastric contents causes a severe inflammatory response when aspirated into the respiratory tract. Pulmonary edema and respiratory failure may result. Common complications of aspiration pneumonia are abscesses, bronchiectasis, which is chronic dilation of the bronchi and bronchioles, bronchiectasis, and gangrene of pulmonary tissue. So this aspiration pneumonia can be very difficult to treat. Risk factors. The immature immune system of infants and young children increase their risk for pneumonia. Older adults that are increased risk because of diminished cough and gag reflexes, as well as diminishing immune responses. Anyone with a compromised immune system, such as those diagnosed with HIV and AIDS, individuals on medication to prevent rejection of a transplanted organ, and those receiving treatment for cancer, such as chemotherapy or radiation therapy, is at increased risk for infection, and for pneumonia in particular. Patients in a debilitated or weakened condition from any cause, including chronic cardiac or respiratory conditions, diabetes mellitus, or alcoholism, also face increased risk. Patients at high risk for pneumonia also face a higher risk for adverse outcomes and complications. Research indicates a high rate of pneumonia in patients with frequent exposure to cigarette smoke because it damages the cilia in your airways as well, and alcohol or drug abuse. Smoking injures tissues on the airways and decreases action of the cilia. Chemicals in cigarettes have a numbing effect on the cough reflex. All of these actions diminish the lungs' natural protective mechanisms. And our lungs protect us more than you realize. They really keep out this bacteria and stuff. Alcohol interferes with the actions of macrophages, while injection drug users are at risk from infections that originate at the injection site and then spread throughout the bloodstream. So you get infection from using dirty needles. Prevention is a key component in managing pneumonia. Identifying vulnerable populations, the young and the old, and people in crowded places, and people who are immunocompromised. Instituting preventive strategies or measures to reduce the mortality and morbidity associated with the condition. With early identification of the infective organism, appropriate treatment and support of respiratory function, most patients recover uneventfully. Pneumonia remains a serious disease with significant mortality, especially in older adults and individuals who are frail or have chronic diseases. Vaccines offer some degree of protection against the most common bacterial and viral pneumonias. Pneumococcal vaccine, made of antigens from 23 types of pneumococcus, usually imparts lifetime immunity with a single dose. The vaccine is recommended for patients who have a high risk of adverse outcome from bacterial pneumonias, including all adults over the age of 65. Individuals with chronic diseases such as heart conditions, lung disease, alcoholism, diabetes, and cirrhosis, individuals with chronic renal failure, individuals who are immunocompromised, those with malignancies, HIV and AIDS and organ transplants, individuals who smoke or have asthma, and individuals receiving chemotherapy with selected agents, radiation therapy, or long-term steroids, and we've talked about steroids before. A one-time revaccination is recommended for selected populations, including individuals with immunosuppressive conditions and adults over age 65 who were immunized more than 5 years previously and before age 65. Safety alert. Annual influenza vaccination helps prevent pneumonia. Inquire about allergic responses to eggs or previous influenza vaccinations before administering the influenza vaccine. A significant hypersensitivity response may occur in patients who are allergic to egg proteins, and we talked about that in the chapter as well. So what do you see with clinical manifestations? You have some terms here: dyspnea, hemoptysis, and cyanosis. These should not be new terms to you. Make sure you know the definition of these terms, because this is how we describe it when we write it in our nursing notes or we put it on the flow sheet. We have to know which words to pick. Infection of the lower respiratory tract has both local and systemic effects. Local effects include cough, excess mucus production, shortness of breath, or dyspnea, difficulty or labor breathing, and hypoxia that may proceed to apnea due to respiratory collapse. Hemoptysis, which is bloody sputum, and chest pain. Systemic effects may include fever, diminished appetite and malaise, cyanosis, gray to blue or purple skin color caused by deoxygenated hemoglobin secondary to hypoxia, and other manifestations of impaired gas exchange. And you can look at table 9-13 and get the manifestations of the pneumonia. They're listed there for you. Bacteria can spread the infection to other tissues, leading to meningitis, endocarditis, and peritonitis, and increasing the risk of mortality. Entry of the pathogens into the bloodstream can result in septicemia, leading to septic shock. So, pneumonia is bad, and once we get septic, it's very hard to turn around. Most people that become septic, the mortality rate is very high. So what is our collaborative process? How do we collaborate? Collaboration in caring for an individual with pneumonia may include nurses, doctors, phlebotomists, respiratory therapists, radiologists, and speech-language pathologists to perform swallow tests. In some cases, consultation with an infectious disease specialist or a pulmonologist may be necessary. Patients who are gravely ill and their families may want the opportunity to talk with the hospital chaplain their own minister, rabbi, or other spiritual leader. And on page 626, you have the clinical manifestations of pneumonia. And as you see, fever, apnea, cough, hypoxia. When you're doing your assessment, you need to look at this. Diagnostic test. Chest x-ray is obtained to determine the extent and pattern of lung involvement. Fluid infiltrates in consolidated lung tissue and atelectasis, which is areas of alveolar collapse. CT provides a more detailed image of the pulmonary tissue and may be used when the chest x-ray is not diagnostic. Sputum gram stain rapidly identifies the infected organism as gram-positive or gram-negative, and I said that determines what antibiotic we use. Antibiotic therapy can then be directed directly at which bacteria it is. Sputum culture and sensitivity are ordered to identify the infected organism, and remember, look at the next one. Well, even with sputum culture and sensitivity, if your sensitivity is greater than 100,000, then with the complete blood count, if you're greater than 10,000, then it's considered an infectious process. Serology testing, blood tests to detect antibodies to respiratory pathogens. They identify the infected organism when blood and sputum cultures are negative. Pulse ox, of course, looks at the O2 sat. The SAT normally is 95% or higher. A SAT of less than 95 may indicate impaired alveolar gas exchange unless the patient is already compromised with COPD or something. They may be living at 90 or below. ABGs may be ordered to evaluate gas exchange. Respiratory secretions or pleuritic pain can interfere with alveolar ventilation. Alveolar inflammation can interfere with gas exchange across the alveolar capillary membrane, especially if exudate or consolidation is present. An arterial partial pressure of oxygen, your PaO2, of less than 75 to 80 millimeters of mercury indicates impaired gas exchange or alveolar ventilation. Fiber optic bronchoscopy may be done to obtain a sputum specimen or remove secretions from the bronchial tree. So they can do that diagnostic test as well. So, medications, pharmacological therapy. Medications used to treat pneumonia include antibiotics to eradicate the infection, bronchodilators to reduce bronchospasms and improve ventilation. Initial antibiotic therapy is based on the results of the sputum gram stain and the pattern of lung involvement shown on the chest X-ray. The presence of cardiovascular disease or residence in a long-term care facility is also considered in the initial antibiotic choice. A broad-spectrum antibiotic such as a macrolide, clarithromycin, azithromycin, erythromycin, these may be used, a penicillin or a second or third generation cephalosporin or a fluocinolone like Cipro or ciprofloxacin. These are typically ordered until the results of the sputum culture and sensitivity come back, and then you know exactly what you're dealing with. When an inflammatory response to the infection causes bronchospasms and constriction, bronchodilators may be ordered to improve ventilation and reduce hypoxia. Bronchodilators generally belong to one of two major groups. The sympathomimetic groups, such as albuterol sulfate, Proventil, and the methylxanthines, such as theophylline and aminophylline. A medication may be prescribed to break up mucus or reduce its viscosity, such as Mucomyst. Potassium iodide and guaifenesin syrup is a common ingredient in expectorant cough syrups. It helps to liquefy mucus, making it easier to expectorate, which means to cough it up. Okay. For many patients, however, increasing fluid intake is an effective means of liquefying the solutions as well. Oxygen therapy may be indicated for the patient who is tachypnic or hypoxemic. Inflammation of the alveolar capillary membrane interferes with diffusion of gases across the membrane. Diffusion is affected by several other factors, including the partial pressure of gases on each side of the membrane. Increasing the percentage of inspired oxygen above that of room air 21% increases the partial pressure of oxygen in the alveoli and enhances its diffusion into capillaries. Supplemental oxygen therefore improves oxygenation of the blood and tissues in patients with pneumonia. Depending on the degree of hypoxia, oxygen may be administered either by a low flow or high flow system. Low flow systems include the nasal cannula, the face mask, partial rebreather, and non-rebreather mask. A nasal cannula can deliver 24 to 54%, 2 to 6 liters. The nasal cannula is comfortable and does not interfere with eating or talking. A simple face mask, 40 to 60%, so 5 to 8 liters, up to 100% oxygen can be delivered by a non-rebreather. The highest concentration possible without mechanical ventilation. When the amount of oxygen delivered must be precisely regulated, a high-flow system such as a Venturi mask is used. The Venturi mask regulates the ratio of oxygen to room air, allowing precise regulation of the oxygen percentage delivered, 24% to 50%. Severe hypoxia may necessitate intubation and mechanical ventilation. As your O2 sats drop and your ABGs change, and you continue to display hypoxia type symptoms, you may end up on a ventilator because your lungs just aren't able to breathe on their own. Non-pharmacological therapies, supportive care for all types of pneumonia include airway management, fluids and rest. When mucus secretions are thick and viscous, increasing fluid intake between 2,500 to 3,000 milliliters a day helps liquefy secretions, making them easier to cough up and expectorate. If the patient is unable to maintain an adequate oral intake, IV fluids and nutrition may be required. Incentive spirometer may be used to promote deep breathing, coughing, and clearance of respiratory secretions. Endotracheal suctionant may be required to clear the throat if the cough is ineffective. Bronchoscopy is used to perform pulmonary hygiene and remove secretions, and so they'll go in there and kind of clean it out. Chest physiotherapy, you can see here on page 629, they're doing percussion. And so it includes percussion, vibration, and postural drainage, and a nurse or a respiratory therapist can do this. You perform percussion by rhythmically striking or clapping the chest with cupped hands using rapid wrist flexion and extension. Cupping traps air between the palm and the patient's skin, setting up vibrations through the chest wall that loosens these secretions. The trapped air also provides a cushion, preventing injury. When performed correctly, percussion produces a hollow popping sound. Percussion may also be done using a mechanical percussion cup. The breast, sternum, spinal column, and kidney regions are avoided during percussion. Vibration facilitates the movement of secretions into larger airways. It is usually combined with percussion, although may be used when percussion is contraindicated. Perform vibration by tensing the arm and hand muscles while maintaining firm but gentle pressure over the affected area. Percussion and vibration are combined with postural drainage, which uses gravity to facilitate movement of secretions. The patient is positioned with the segment to be drained superior to or above the trachea or mainstream bronchus. Drainage of all lung segments requires a variety of positions. Rarely do all segments require drainage. Administer bronchodilators or nebulizer treatments as ordered before postural drainage, because you want to loosen it up. Perform postural drainage before meals to avoid nausea and vomiting. So, lifespan considerations. The population that are most susceptible to pneumonia include young children and older adults based on the risk of airway obstruction, physiologic changes that decrease airway clearance of infecting organisms. Pregnant women are at increased risk as well if they have a history of smoking or a recent infection themselves. The immature airway of the child makes children more susceptible to the development of pneumonia. The primary physiological aspects of the immature lung that contribute to pneumonia severity are the size of the airways, number of alveoli, differential use of muscle for breathing, and higher oxygen consumption. Oxygen consumption is higher in children than in adults because the children's greater metabolic rate. This rate of oxygen consumption increases further when the child is in respiratory distress, thereby causing a quicker getting to a loss of level of consciousness is what I'm trying to say. The child also has fewer muscle glycogen reserves, leading to more and more rapid muscle fatigue when accessory muscles must be used for breathing. As a result, children become hypoxic more quickly than adults. Tachypnea, retractions, nasal flaring, opening of the nares on expiration, and an attempt to draw in more air and increased effort of breathing may tire the infant or young child and result in periods of apnea, absence of breathing, which is not good. Physiologic differences in children affect the clinical manifestations of pneumonia. Symptoms include fever, tachypnea, rhonchi, crackles, wheezes, cough, dyspnea, nasal flaring, restlessness, chest pain, and malaise. Decreased breath sounds may be present if consolidation exists. The child also may have poor oral intake, nausea and vomiting, and abdominal pain. In children over 12 months of age who have clinical manifestations associated with pneumonia, a respiratory rate greater than 50 and an oxygen saturation of less than 90% are associated with a positive chest X-ray. In children are more likely to be associated with a positive chest X-ray. In children under 12 months of age, nasal flaring is an important assessment finding that is more likely to be associated with a positive chest X-ray. The older child may have dullness to chest percussion, increased fremitus, which is felt on vibration, and egophony, increased resonance of voice sounds. There is no clinical way to differentiate the bacteria from the viral cause of pneumonia because it is difficult to get in a sputum culture from a child. Blood cultures may be taken. In children over 5, pneumonia is caused primarily by bacteria Streptococcus pneumoniae. The child's age, severity of symptoms, and the presence of underlying lung, cardiac, or immunodeficiency disease create varying responses. Children with a condition such as cystic fibrosis or immunosuppression are susceptible to many other bacterial, parasitic, or fungal infections. Pneumonia in children often resolves much sooner than adults. The key is early recognition, enabling the child to be treated at home. Because of the differences in the child's anatomy and physiology and related manifestations of pneumonia, assessments of pediatric patients is different than that of adults. Look at table 916 and 915 for some just good information. Assessment guidelines for pediatric patients for fluid requirements of the pediatric patient. See these tables. A liberal fluid intake helps to liquefy secretions and facilitate their clearance. In pediatric patients, rapid fluid replacement is indicated in sepsis conditions as well as appropriate pharmacologic interventions. While aspirin may be used with adults, aspirin is never prescribed for pediatric patients because of Reye syndrome, and we talked about that. In the older adult, several changes associated with aging and disease affect respiratory function and airway clearance. As an individual ages, the number of cilia decreases and the gag and cough reflexes diminish. The older adult is at greater risk for dehydration, leading to thick, viscous mucus that is difficult to expectorate. Immune function declines with aging as well. These factors increase the risk of pulmonary infection and reduce the older adult's ability to respond effectively to infectious processes. Other factors also may increase the risk for and severity of lower respiratory infections in the older adult. These factors include immobility, smoking history, surgical procedures, use of multiple medications, malnutrition, and diseases such as COPD and heart disease. Pneumonia in the older adult can result in continued respiratory failure, organ failure, complications throughout the body such as sepsis or even death. There is increased risk for hospitalization for community-acquired pneumonia in older adults with a chronic cardiac disease. Pneumonia and the related complications in the older adult are one of the common reasons for an ICU admission and remain a common concern still today. It's still a big issue with older adults. Nursing process. Pneumonia can quickly escalate from minor to severe disease if not treated. Adequate assessment and implementation of medical and nursing interventions are vital to the healing process. Frequent pulmonary assessment and aggressive interventions help to prevent problems. Restoring and maintaining mobility, improve ventilation, and help to mobilize secretions. Promoting adequate fluid intake is necessary because fluid helps to liquefy secretions, making them easier to expectorate. Observation and patient interview. You want to look for shortness of breath, difficulty breathing, presence of a cough, and what's the nature of the cough? Is it dry or is it productive? Is it non-productive? What's the color of the sputum? What's the consistency of it? How does it look? Is it thick, yellow, green, clear, rusty? Current symptoms and how long have you had them? Describe your chest pain. Does it hurt to breathe? Have you had other infections? Do you have chronic diseases? Are you immunocompromised? What type of medications are you on? Do you have a history of asthma? Do you have a history of COPD? And have you had your immunizations? The physical exam, examine the patient's current presentation and any apparent distress. Assess the level of consciousness, collect and evaluate vital signs, including temperature, see if they have a fever. Examine skin color, look for cyanosis, and if they're cool and clammy or warm to touch, because again, they may have a fever. Respiratory exam focuses on respiratory excursion, use of accessory muscles to breathe, and thorough assessment of the patient's lung sounds. Examine the patient's current oxygen saturation reading as well. So don't just do a head-to-toe assessment, and with your vital signs, make sure that you get an O2 sat as well, because this will tell the story. Ongoing respiratory assessments. Assess them every time you go in the room. Make your assessments frequent. Auscultate breath sounds and measurement of vital signs and O2 sats frequently. Here are your nursing diagnoses: ineffective airway clearance, ineffective breathing pattern, You could also have impaired oxygenation, impaired gas exchange, hyperthermia, activity intolerance, anxiety related to hypoxia, impaired nutrition, sleep disturbances, multiple things with pneumonia. Planning. The patient will maintain normal temperature for 24 hours. The patient will obtain adequate sleep and rest without interruption from coughing or orthopnea. The patient will maintain adequate fluid and caloric intake. The patient will demonstrate a strong cough sufficient to clear the airway. If they don't, we've got to help them with something, give them something else. The patient will maintain oxygen saturation greater than 90% and will not require supplemental oxygen. Implementation. In addition to teaching the patient to take all the antibiotics and other medications as ordered, nursing care focuses on supporting optimal respiratory functions such as maintaining airway patency and an effective breathing pattern and promoting rest to reduce metabolic and oxygen demands. Nursing interventions are prioritized on the basis of the most important nursing diagnoses: ineffective airway clearance, ineffective breathing pattern, and activity intolerance. So what do we see in community-based? If the patients are stable enough in managing their respiratory needs as expected for their age and health condition, they may go home after an acute stay in the hospital. Many patients with pneumonia will recover at home. Patient teaching is as important nursing intervention. Discuss the following: the importance of completing prescribed medication, potential drug side effects, how to manage them, including manifestations that necessitate stopping the drug and notifying the healthcare provider. Recommend for limiting activities because you need rest. You don't want to burn up energy. Maintaining adequate fluid intake. Keep those secretions thin. Ways to maintain adequate nutrition: small, frequent, well-balanced meals, protein shakes, things like that. Importance of avoiding smoking or exposure to secondhand smoke. It prevents further irritation to the lungs. Manifestations to report: increasing shortness of breath, difficulty breathing, increased fever, fatigue, headache, can't sleep, or confusion. The importance of keeping all the following appointments to ensure disease is cured. Maintain airway patency. For the patient treated in the hospital, the focus will be on airway and infection management. Infections of the lower lungs generate sputum that hinders respiration, decreasing O2 sats and making it difficult for the patient to breathe. There are several nursing assessments that must be done for these patients with the respiratory illness. Assess the patient's respiratory status, vital signs, O2 sats, skin color at least every 4 hours and more if needed. Early identification will bring on a quick intervention. Assess the cough and sputum, amount, color, consistency, possible odor. Assess the cough and nature of the sputum produced. Assess the effectiveness of the cough. Are they clearing? Look for ABG results. Report increasing hypoxemia, deficient blood oxygenation, and other abnormal results to the healthcare provider. Place the client in high Fowler position. Encourage frequent position changes and ambulate as allowed. But the first thing you do is put the head of the bed up. Assess the patient to cough, deep breathe, use assisted devices. Coughing, deep breathing, and suctioning help to clear airways. Fluid intake, 2,500 to 3,000 milliliters per day. Work with the healthcare provider and the respiratory therapist. Postural drainage, percussion, and vibration. Administer medications as ordered. If the infecting organism is resistant, then we need to notify the doctor and make sure they take all of it and give them their bronchodilators. Maintain patent airway and ventilation. Endotracheal suction again as ordered. 2,500 to 3,000 milliliters of fluid a day. Again, the postural drainage, percussion, and vibration. Effective ventilation, let them rest. They need to conserve their energy. Assess for pleuritic discomfort. Adequate pain relief minimizes splinting and promotes adequate ventilation. Analgesics, ibuprofen, and acetaminophen can be added. Teach patient how to splint the chest to make coughing less painful. They can use a pillow to help them cough. Provide reassurance during, respiratory distress, because they're scared and they're anxious. Administer oxygen. Teach slow abdominal breathing. Teach the patient to slow their breathing down and use relaxation techniques. Safety alert. Assess respiratory rate, depth, and lung sounds at least every 4 hours for adults, at least every 1 hour, 1 to 2 hours for children. Tachypnea and diminished or adventitious breath sounds may be early indicators of respiratory compromise. Promote balance between activity and rest. They need to rest. Assess the patient's activity tolerance, noting any increase in pulse, respiration, shortness of breath, or dyspnea, diaphoresis, or cyanosis. They need to be able to just have time where they can sleep. Assess the patient with self-care activities such as bathing and dressing, ADLs. Schedule activities for rest periods. Monitor vitals, at least every 4 hours. Help them with range of motion and provide emotional support to the patient and the family. Ask the family to help you. Provide emotional support each time that you can, because this helps assure that they're feeling more comfortable and they will rest better. Safety alert. Activity intolerance may be an early sign of cardiorespiratory compromise, particularly in the older adult or patient with pre-existing heart disease. New or worsening manifestations of activity intolerance should be reported to the healthcare provider. An evaluation, usually treated in the community, teach caregivers to evaluate signs and symptoms, when to consult the primary healthcare provider. Patients who lack appropriate airway management likely will be admitted multiple times. And so the patient maintains normal temperature for 24 hours. They get adequate sleep, adequate fluid and caloric intake, demonstrate strong cough sufficient to clear the airways, and their O2 sats are greater than 90%. So pneumonia it can be a difficult, if it's caught early enough, they can get them on the right antibiotic and get them treated. If it gets too far gone, the patient can become septic and lead to mortality. Thank you.